Welcome back, everybody, to the Poor Prognosis Podcast. This is a podcast that focuses on the healthcare system beyond the clinical side, where we look at the finance and the corporate aspects of healthcare. With me today, I'm joined by Professor Michael Richards. How are you doing today, sir?
I'm doing great. It's good to see you, Hassan.
Thank you. You too. So today, we'll be talking about the economics of healthcare. And Professor Richards, would you mind just telling the audience why you're credible on this topic?
Sure. Healthcare is something I can say I've devoted my entire adult life to. So since the age of 18, I've been in and out of healthcare in a variety of different ways. So I started in the clinical space, including going to medical school and getting some public health training while in medical school. But during that time, I decided that instead of staying as a clinician, I'd like to transition more toward the research element, the scholarship, the academic and policy side of things, as well as teaching. And that drew me to the economics of healthcare, where I ultimately pursued a PhD degree, did some postdoc training around that, and since then have been a faculty member at both Vanderbilt University and now at Baylor University, where I continue my research, try and influence policy in good ways, and then importantly, get to teach great students.
Wow, perfect. I guess we can just start with our list of questions. So the American economy, most people would probably classify it as a capitalist system with some governmental regulation involved here and there. How would you describe the current status of American healthcare?
Yeah, so that's one of the many complexities of the American healthcare system is it is very much a hodgepodge. It's often remarked of how different the American healthcare system is to other countries, how our health outcomes are different, and so on. But one of, to me, the most salient differences that probably is impetus for these other differences is just the fact that we are a collection of a lot of different styles of healthcare systems. So if you even just look around at the different pieces of US healthcare. If you look at the over 65 crowd, you'll see something that looks very close to the Canadian healthcare system, where we have this single payer Medicare style program. But if you look at the largest chunk of the insured population in the US system, you'll see health insurance based very heavily on employment, which is similar to other countries that have linked health insurance and employment together. If you go over to, say, the VA, you'll see an actual socialized system, much more similar to like the National Health Service there in England, where the government is not only financing the care, but actually owns, the facilities, they employ the providers, and so on. And so if you look at all the different pieces that we have in this amalgamation of US healthcare, you'll see all of these different styles of healthcare systems, some of which rely more on government control and intervention. Some elements rely more on market forces. And I don't think that that's actually to our advantage. I think it actually creates a lot of policy tension and difficult policy choices, because inevitably these different pieces are going to interact, and sometimes it's in counterproductive or conflicting ways. And I think it creates a real challenge for health policy and health reform, because all of the different pieces are different, and so they're dealing with different issues in different ways. And so it's hard to have this kind of unified approach to health policy to really move us into a better performing, higher performing healthcare system that's also more efficient and more fiscally responsible.
When I've talked to many physicians, they always describe the healthcare system as fragmented, but I'd never thought about it in terms of like the niches you talked about, whether it be the VA or the Medicare population. So you're saying that there's no kind of centralized hierarchy where somebody at the end of the day has the final say or has the most overarching scope of who they're talking to, who they can regulate. There's nothing like that in America.
Yeah, exactly. So oftentimes we think about fragmentation and even lament fragmentation when we're thinking about the clinical connections, the flow of information, the patient care that comes with it. But really, when you zoom out and go up 50,000 feet, you realize it's also fragmented up there, because we have these different independent yet overlapping pieces, which all kind of fall on this gradient from more market-driven, decentralized, to more centralized decision making, more government run and government influence. And so it's a very complex entity to then work with. And it's one of those things that when people say, how do you describe the American healthcare system? It's a patchwork. To some extent, it's actually just a bucket of several different healthcare systems collected together.
Yeah, there's definitely a lot of ways to think about fragmentation. I think one aspect is the patient who very much feels like they've been sidelined in a lot of instances in healthcare. So I wanted to ask you, when a patient goes to the hospital, they can't really go to the doctor or some like salesperson or whatever. They
Mhm.
can't ask them how much does an MRI cost or how much will this surgery cost. They only find out after the surgery's been completed and they get that hospital bill months later. So could you just briefly explain why that system exists?
Yeah, well, so for one thing, some of that is changing rapidly as more price transparency initiatives are being rolled out, and there's trying to be more consumer-friendly, consumer-accessible tools to actually find out some of those answers ex ante as opposed to ex post, which has historically been the scenario that you described. But in terms of why that exists, I think there's a few pieces of nuance that we should keep in mind. So one of which is, at least on the commercial or private side of health insurance and healthcare delivery, overwhelmingly historically and certainly today, those prices are just determined by a negotiation process. So the private insurers and the providers, the hospitals, the physician practices, the imaging and testing centers, whatever piece of the supply side of healthcare is involved, they're having this negotiation, this bargaining game play out. That's ultimately going to determine the prices for the individuals enrolled in that insurance plan and ultimately seeking that care. And for the most part, a lot of these different parties involved in the bargaining process have viewed that as proprietary information. So it is a kind of a reflection of their own strategic endeavors and efforts, and ultimately how it's played out. And some people are very uncomfortable with that, and have been pushing for more kind of price transparency in order to shed some light on that. And I don't necessarily think it's a bad idea to offer more price transparency, insofar as we think it might promote competition, although there are some risks that it can go the other way. We can touch on that, but sometimes that's a little too far into the weeds. But I think a broader point that many of your listeners should be aware of is, at the end of the day, it's only a minority of really healthcare consumption, healthcare utilization that we could really classify as shoppable, meaning that, if consumers had more information, if they knew what their options were, if they knew the different prices and costs attached to those options, we could expect them to act on that decision. But at the end of the day, the majority of utilization, the majority of healthcare dollars we spend in a given year don't really fall into that kind of shoppable classification. And so, just to give a concrete and somewhat extreme example is, imagine an individual experiencing a heart attack. So that's not going to be the right time to say, well, we have 4 hospitals in your local geographic area. The different hospitals are saying that for a cardiac hospitalization, you might expect this price and this price and this price and this for the imaging that's going to come with it. Where would you like to go, right? Like that's just not going to work out in that type of setting. And so I think it's important for us to not be overly confident in viewing that price transparency initiatives are going to be the silver bullet that makes U.S. healthcare more efficient. We're going to bend the cost curve and these sorts of things. It can be beneficial when used well and in the right market circumstances. But at the end of the day, we have to use a cliche, some bigger fish to fry when it comes to really moving toward more efficient, higher quality healthcare delivery. And I think that really actually reflects broader payment reform. So your listeners may have heard of the terms like value-based payment reform, which can mean a lot of different things. It's a fairly broad umbrella, but the broader theme is, again, trying to add more efficiency in order to get as good or better quality care at the same or lower cost.
I think that'll tie in well with our next point, which is supply and demand and how those forces need to work for competition to even happen. And just for the viewers, the basics of supply and demand, I'm sure most of you know, but actually, I'm sure the professor can explain it better than I can. So I'll leave that to you. But my question is, after you explain those systems of supply and demand, does healthcare work along those rules that have been kind of set up?
Yeah, so in many of our kind of basic, economic textbooks and lessons, and even online slide decks, I'm sure your listeners could view. In general, when we think about the supply curve, it tends to be upward sloping. So as prices are more attractive to firms and suppliers, they tend to increase their output in quantity, and so they respond to those price signals. Similarly, when we're thinking about demand curves, we tend to think it's downward sloping. So as things become more expensive, individuals tend to consume less of them. Now, in terms of how those supply and demand responses and their intersection, their kind of equilibrium results apply or materialize in healthcare, things get quite complicated. And actually, really the field of health economics, the academic discipline that I'm most attached to, in some ways kind of got its launch back in 1963 when a Nobel laureate in economics, Kenneth Arrow, wrote a nice essay really describing all of the complexities and nuances and intricacies of medical care transactions, and how these different features create some both distortions and departures from our basic understanding of kind of how supply and demand responses play out. And so, there's a variety of different features that are inevitable pieces of medical care transactions. So one of which is insurance. So at the end of the day, for folks holding a health insurance plan, they don't actually face the full cost or the full price of a given service. And instead, it's only a fraction of that they're ultimately considering. And so their demand response is going to be a reflection of that influence of insurance. And then on the supply side, those price signals aren't just coming from kind of the free market game being played out in a local area or local market, but instead are also influenced by this mixed economy feature we have in healthcare, which means both there's a private sector as well as a public sector that's heavily involved. And so suppliers, healthcare providers, hospitals, physician practices, and so on, are not only negotiating with private insurers and participating in those bargaining dynamics, but they're also having to pay attention to, well, what's going on with Medicare, what's going on with Medicaid, what sorts of price signals are we receiving from the public sector or the government side of healthcare, and how is that going to affect whether we increase our output or we decrease it, or even change the scope of services that we're providing to care. And so it's these inevitable features of a healthcare system that make supply and demand more complex than it would be in a lot of more kind of traditional markets where you have just essentially the private sector determining supply and demand. Consumers are paying fully out of pocket. There's free entry and exit of firms and all these sorts of things. There's no insurance function. But in medical care, we have all of those things. And so it makes it a really fun environment to research in. It makes it a really fun environment to teach about. But it also means that we have to have a much more nuanced and a much more richer understanding of the microeconomic principles in play.
Absolutely. Yeah. So obviously, supply and demand in healthcare has become complicated because you have these middlemen like insurance companies. So it's not a payer provider dynamic anymore. So in that case, who exactly is determining how much treatment costs? Because that's what I've been confused about.
Yeah, so it's another area where there's quite a bit of nuance and quite a bit of complexity. So in the simplest description, we could kind of think of the privatized side of the market as participating in this negotiation between the providers and the commercial or private insurers, and in order to arrive at some agreed upon price for services. And then on the public side, we kind of think of the providers as typically more of price takers, meaning, the Medicare program says we will pay X dollars for that service. And so if you provide that service to a Medicare beneficiary, you can expect X number of dollars in reimbursement. But even that kind of simple demarcation is too simple, in part because we have empirical evidence and a lot of industry knowledge that has demonstrated that the prices set on the commercial side often have linkages to what's going on the public side. And so when it comes to these private insurers or commercial insurers and their contracting, they often use Medicare as a bit of a public good, meaning that they use the price schedule or the fee schedule that Medicare establishes as a starting point for negotiations. And so it's not uncommon for a commercial insurer to contract with a provider and say, well, we'll give you 140% of the Medicare price. And so will you accept that fee schedule from us? And part of that is a reflection because there are so many different services. It would be really costly and take a lot of time and effort to negotiate over every single one. And so they can kind of use the Medicare price schedule again as this kind of public good to say, well, can we give you a markup of Medicare or a multiple of Medicare? But even on the Medicare side, how those prices get set are quite complicated. And so back in the thinking about physician services specifically, so for the thousands of different things that physicians services they can provide, and therefore the thousands of different prices that can be attached to them, back in the 1980s, there was a really extensive study to try and measure the cost of providing those services. So looking at the time use, looking at the different clinical infrastructure that was needed, looking at just what the physician ultimately had to do and kind of the complexity of the procedure or the service that was being provided. And that was used to establish this kind of menu of services and prices. But as you could imagine, this multi-year effort has not been repeated since. And so now, here we are decades later, where we still have to update this fee schedule, but we're not doing it through that kind of on the ground intensive cost analytic exercise. Instead, we're doing it usually through political processes. And so some of that depends on how the political process shakes out in Congress, kind of what the priorities are and different legislative groups and caucuses, how they feel about the Medicare program, if they think spending is too high, too low, distorted in some way. So that political process is going to shape Medicare fees and reimbursements going forward, but also providers shape the Medicare fee schedule. And so different physician organizations, as well as other healthcare provider organizations, make formal recommendations and have a lot of influence on shaping, the Medicare fee schedule. And if it's tilting payments or reimbursements toward one type of service versus another. And so they're going to have that own kind of political economy dynamic playing out. And so even when we think about things in the simplest setup, there's still this pretty rich, pretty complex process that's shaping the ultimate price that we see on the private side or on the public side.
Yeah, wow. I did not know that there was an extensive research study to figure out the prices of Medicare. I don't know why, but I thought that would have been a lot simpler to figure out how much a test costs or anything like that.
Absolutely. And so I think, for a lot of us, when we think about, Medicare, knowing that it's a federal government run program, we tend to, picture somebody sitting down in a basement, with a big spreadsheet, adjusting the prices, for inflation or changes in medical technology. But in fact, that's not the case. It's actually this complex political economy that is playing out year after year after year, which might lead to improvements in incentives, or might actually lead to further distortions or things that we might view as inefficient outcomes for both the Medicare program and the broader healthcare system. And then importantly, just to throw in one other thing is we have to keep in mind that overwhelmingly on both the private and the public side, when it comes to incentives for providers, we overwhelmingly rely on the fee-for-service style of payment, which for many types of care, many clinical scenarios and contexts, is a probably undesirable, payment model or incentive structure, because it incentivizes overutilization. It incentivizes more intense care when maybe more conservative care would be better. It doesn't reward quality, so there's no differentiation, and it ultimately creates this high-powered incentive to always do more. Even if doing more is a reflection of a mistake that had been done previously. And so that's another way that kind of the value-based payment models are trying to kind of push against that and really bring us to a new state of the world in terms of the incentive structures for providers and the functioning performance of the healthcare system, is because this whole kind of pricing dynamic, both the private and the public side, has not led to probably an ideal or optimal state of the U.S. healthcare system. And so it's where we have a lot of opportunity to improve, and also where hopefully, as many of our listeners might be future providers, future clinicians, or future healthcare industry stakeholders and influencers, that they will actually help us in that transition, because we've kind of been stuck in doing it the old way for too long.
Are there any legislators who are currently trying to push for that reassessing Medicare prices? Has that hit Congress at all yet?
There is always conversations about the fiscal sustainability of Medicare specifically, and really U.S. healthcare more broadly. But the historical experience is not doesn't lead to a lot of optimism about change. So different times when there's been bipartisan agreement to look into reforms, to propose reforms, to even make reforms, those have tended to be short-lived. And so either the actual reforms aren't even put on the table, or if the reforms have been enacted, they're quickly reversed. And I think that is a great illustration of some of the underlying tension of U.S. healthcare and U.S. health policy. So at the end of the day, I like to think of the study of economics, whether it's applied to healthcare or anything else, as really a study of trade-offs. And so economics is very good at being able to illustrate the important trade-offs that are made in any type of decision, whether it's on the consumer side and consumption decisions, whether it's on the supplier side and firms' decisions, or higher up at kind of the government and public policy domain. We're good at demonstrating and diagramming what the trade-offs are, and good at analyzing them in terms of their downstream implications and consequences. But from a political standpoint, it's probably not a stretch to say that trade-offs are undesirable. Right? You rarely will hear any politician of any stripe stand up and say, I have a good idea, but I want to be clear, it's going to have these costs and these downsides. But I think on net, we're going to be better off. You will, I think, struggle to find anybody willing to make that speech. It would be an honest and correct speech, but not one that anyone wants to make, because inevitably it's saying that some group of people are not going to have everything they want, or some group of people are actually not going to gain from this, but actually may lose some stuff if funds or resources are redistributed, or a program is wound down so another program can succeed, or we tried to actually harmonize our delivery of health insurance so that we didn't do it 5 or 6 different ways, but instead had a common and uniform way of health insurance delivery, whether it's through more reliance on the private market or more of a government run, whatever approach society might decide to take. Just trying to harmonize it is difficult, because there's always going to be a constituency that is not going to be receptive to the idea that they might get less rather than more, or they're not going to get the same thing that they wanted. And so the idea of being clear about these trade-offs and ultimately making these trade-offs can be a very difficult political hurdle to clear. And that's true regardless of political affiliations or different, regions of the country, wherever it may be. It's just really hard to get past that political inertia.
So the last thing I wanted to cover was just health insurance, but from, just health insurance compared to other types of insurance. I think most people, when they hear the word insurance, it's synonymous to risk assessment. Like I buy this insurance package because if something happens to me, I'll get reimbursed. And that works for car insurance, home insurance. If something happens, you get reimbursed. But health insurance does not really work like that anymore, or if it ever did, because I think most people know that at some point in your life, you will be visiting the doctor, you'll be getting that hospital bill. It's just inevitable at this point. So my first question is, has it always been like that? And did something happen to cause health insurance to work differently?
So you're hitting on a really important point, which is the fact that health insurance is really not the type of financial instrument of most other insurance products that you can find in the market. And you brought up two excellent examples of automobile insurance and life insurance. I think are great examples to contrast with health insurance. And I think so. You're touching on one of the important points, which is, inevitably someone is probably going to interact with the healthcare system at some point in some way. And I think a kind of a related point to make with that I think illustrates how health insurance is different and inevitably will be different is when we think about all of the eventualities that the insurance product is trying to deal with. So at the end of the day, life insurance is dealing with one eventuality, which is early death, early untimely death. And so the trade that is being made between the life insurer and the individual that is purchasing the life insurance plan is this shifting of risk around that eventuality of, should you die younger than expected, there is going to be a financial transfer to the beneficiaries that you designate. And so it can be, loved ones, family members, whatever it may be, that this financial transfer will happen should you not live as long as you would be statistically expected to live. And so it's really one event that the insurance contract has to cover. When thinking about automobile insurance, it's also fairly close to one event. Now there are a few more gradients of the event, but it's really it boils down to the same thing of a damage and ultimately financial loss to your insured automobile. So regardless of how it might happen, you know the value of your automobile, and you insure that value of that automobile. And then if there's an accident, there's some sort of environmental storm and damage done to the automobile, you're able to get that financial transfer to effectively make you whole, so that you can either repair the asset or replace the asset. And there's a few more layers of nuance with automobile insurance, mostly around liability of, should you damage someone else's property or cause physical harm to someone else, that the insurance plan will cover that as well. But again, it really boils down to a very few potential outcomes or eventualities. But now health insurance is clearly going to have to be different, right? So in theory, you could write a health insurance contract that specified for every health event you might experience, acute or chronic, the insurance contract will generate a payout. It will say, okay, you've been diagnosed with health problem X. We will give you Y dollars in compensation. And you can use those Y dollars however you need to. If you're not able to work, maybe you use that to help pay your rent and cover your groceries. If you need that to go get treatment so that you can remedy the health problem, that's fine. You have the Y dollars to use them however you want, because at its core, that's how life insurance and automobile insurance are doing. There's a very clearly specified event, and should that event happen, you can expect a transfer of this amount of money. And so we could try and do that same thing with health insurance, but I think pretty quickly you and your listeners could imagine all of the different scenarios and outcomes that would have to be covered, right? All of the different illnesses, and then how those would map to the amount of money that people would need to be transferred in terms of different types of treatments and different types of providers they could be seeing, how it would impact their working and maybe even family care responsibilities. Would it affect them for a short term or a long term? All of these different things. And so we don't have health insurance contracts written that way, in part because it would just be incredibly costly and virtually infeasible to do. So health insurance actually does something different. What it does is essentially insure you against having to pay the full out-of-pocket cost for the medical treatments that you require. And so it's protecting you against the the full financial implications of illness, as opposed to establishing a financial transfer based on an unexpected and undesired outcome. And so that is a very clear way health insurance is different from insurance products, but it's one that we can't get away with, which is also another reason why I think we want to, when it comes from a policy standpoint and thinking about how our health insurance market's working, how are we dealing with, uninsured individuals, either certain populations or in certain regions, how are we dealing with the delivery of health insurance? We need to also accept the fact that it is this special and unique product. And so we want to think about how do we finance it? How do we set up the incentives in the best way so that the health insurance market functions in its best possible way, given that it has to do something that is distinctly different from other insurance plans that probably need less, regulation, and in some sense, less help in having, a good functioning market, like what you see in life insurance and what you see in automobile insurance.
Great. I know we're running out of time, but I just wanted to ask you, I definitely learned a lot about the economic side of healthcare, but I also have many more questions, and I've probably been left more confused, honestly. But can you recommend any books or reading just for people who are still interested, just to kind of take a deeper dive into this subject?
Yeah, so there's a variety of health economics textbooks that I've certainly enjoyed over my academic career. So I would, frankly, for any of your listeners who really want to engage with it more, if you just do a little bit of light internet searching or go to your favorite online shopping platform, you will find a variety of books that have been written on the US healthcare system and health economics specifically. And what's nice about it is not only is there a good supply of quality resources, but also a variety of the authors have been intentional about what level they're trying to speak to. So someone who may have very little economics exposure or background versus those who may be either pretty advanced in their economics knowledge and or have lots of industry experience to draw upon, and then all of the gradients in between. And so with a little bit of reading, the description of the book and a little bit of the customer reviews, I think it's actually relatively easy to find one that's right for a given person's kind of level and exposure. And so there's a good set of resources without me having to endorse any particular one. I think you'll find plenty, and we'll hit the right technical level for any one person. The other thing I always recommend is certainly for listeners who are currently in school, in a college, university, or other academic setting, is to actually seek out courses related to healthcare. So it's because it's such a large sector in our economy, because it's a big source of employment. Many higher education entities will have courses devoted to healthcare specifically, which will very much embrace, what kind of the meta theme that we've been talking about today, which is healthcare is special. It's special in good ways, in that it creates an opportunity to help people, help their health trajectory, help them live happier and healthier lives, but also, when we're thinking about the financing, the efficiency, the market function, it is deeply challenging and deeply complex. And so you'll find, courses that are able to kind of live in that tension, live in that space, to help build a knowledge base. Because I can tell you, as someone who's been doing healthcare since the age of 18, I'm not going to tell you my age, but it is higher than 18. I'm still learning new things every day. Which I love, because it lets my research be more exciting. It lets what I do in the classroom be more fun, but it just gives you some idea of just kind of how much there is there. You're kind of constantly peeling back the layer of the onion. And so I think that's kind of the way to think about it, that really it is almost, kind of an academic and even professional lifelong pursuit to understand it more, and to be able to embrace the complexity, but also, to be optimistic, and that I think there is a lot of great opportunity and great potential to do better. I think we can and should do better as a healthcare system, and I think we're able to do that. And one of the ways we're able to do that is if a lot of future healthcare professionals and healthcare leaders are doing what you and your listeners are doing now, which is actually investing in learning, so that kind of the historical evolution of these things. You understand when things are working well and when they're not, and why that may be the case. Then that creates the space and the opportunity for us to really improve. And instead of kind of paying lip service and offering a bumper sticker about health reform, actually doing health reform in a successful, fiscally responsible way.
Professor Richards, thank you so much for just bringing your expertise to the table. It's really nice to hear the perspective of someone who has his MD, but he's also really looked into the economics of healthcare and just all these different aspects that are so relevant to what we need to do if we actually want to help patients. And so I really thank you for coming onto the podcast. I think you've earned yourself a free advertisement. So is there anything you'd like to plug to the people?
Well, I would just say that for any listeners out there who are thinking about either undergraduate or master's or PhD academic programs related to healthcare, we have several of them here at Baylor. I teach and am heavily involved in all of them, and so I would love to hear from any interested listeners out there who might want to come and spend some time at Baylor. You'd certainly be welcome.
That's it for this episode of the Poor Prognosis Podcast. Take care, everybody.